may I just share some of my experience here in UK, just to fill some of the time? Just to say, we are going through the second wave of coronavirus in UK. We had initially very intense sort of period in March, April, and May, where most of NHS work sort of almost stopped, and we were looking after COVID as the primary thing. And that meant all our routine work, caring for our ischemic heart disease and heart failure patients, and everything came to an end. And I think corona has two things. One is that it has its direct effect on the body, including the heart, but it also has a significant indirect effect. I lost a patient who was waiting for a balloon mitral valvuloplasty, and she refused to come into the hospital, and she came in extremis in heart failure. She was COVID negative, but basically died primarily because she wouldn't come to have her procedure done, fearing that she will catch corona and she won't survive. We've had patients not presenting with a heart attack, coming to the hospital 10 days after they've had an anterior MI, with completely short ventricle, which is then required ICD insertion and things like that. So I think it's one of those things that we have learned to live with, and it's completely changed the way we practice. I don't know how it's being done in India, but most of my clinics have now become virtual. So I don't examine my patients as I did before. I talk to them on the telephone and make judgments. We have things where we run chest pain clinics, etc. And sometimes you come across some gross errors. One of my patients with chest pain, who was referred to the chest pain clinic, had very atypical symptoms. And we thought that, this is non-cardiac pain, as most of the patients referred to the clinics are. And the next day, she got admitted with a cardiac tamponade, and clearly she had pericarditis, which was, progressing. So things like that, where we don't examine the patients, are going to come back to bite us, and some of these things are going to stay. We are now investing in a large sort of process of having electronic patient records, which we are hoping will tie up some of these things, and there will be a better video consultation being instituted, by which we can see most of our patients, and then perhaps have consultations with them and bring in patients where we think something has to be brought in. So one of the things that's affecting us most, besides all these things that the previous speakers have said, is that it's now become quite difficult to do the routine kind of work that we were doing before. So patients getting admitted with, for example, ischemic heart disease, where they have a STEMI, ST elevation MI, they go directly to the cath lab and they have their procedure done then and there. Now that requires us to wear a full PPE. We reduce the number of patients who will be entertained in that lab. And we have to high clean the lab every time we do a procedure. And every patient with a STEMI is assumed as having COVID, because we can't prove that they don't have COVID by the time they are taken to the lab. But for non-ST elevation MI, where there's less sort of urgency to do their angioplasty, these patients get admitted to the ward after they have been proven that they are COVID negative. Then they wait for a slot in the cath lab. The cath labs are now become stretched and underutilized, primarily because of the logistics. And that's meant that some of the patients are then rationed with other scoring, such as GRACE score, so that we can try and see who needs to go to the lab quickly and who doesn't. And this has meant that some of the patients that we would perhaps have done an angioplasty on are sent home on medical therapy. We don't know what the long-term consequences of these things are going to be, whether they're going to infarct or whether they will behave the same way as they did before. The other important thing at present is that our hospitals were never designed. I was very impressed with the presentation from Chennai, where they designed the wards and they have a COVID ward and things, which is remarkable. I mean, it shows how good India is in terms of organizing things. NHS, unfortunately, isn't that good. Our hospitals were built about 30 to 40 to 50 years. Some of them are 100 years old. And the wards are not convenient to isolate patients in. And they have general wards which end up with lots of patients who are non-COVID, and we can't mix the COVID with them. And that's basically meant that there are patients who come for routine procedures such as an ICD or a pacemaker. They can't be taken into a general ward to recover. So I've had patients electively coming into the lab, getting an ICD or a CRTP, and then going home within half an hour. Things that we would have perhaps taken 3-4 hours, got a chest X-ray done on them. So we're learning new skills. I don't know whether this is going to become more permanent in the future. And it's one of those things that worldwide we're going to have to adapt. We have patients with heart failure who would normally have visited the hospital frequently. And there's an immense amount of fear in these patients to visit hospitals. So they tend to be at home. So there's a move now to start looking at heart failure therapy in the community. So that there is a move to try and see if we can get intravenous furosemide done in the community rather than in the hospital, which basically meant that we've got to get a system right, who looks after these patients, how it's going to be done. And there is reinvigoration of home monitoring of these patients with regards to their hemodynamics and blood pressure and things. And there are companies that are trying to see if there is a way of getting such as things as blood pressure, heart rate, and things done at home, and whether that could be tied into a kind of web-based central monitoring that will allow us to monitor these patients significantly. I think these are things that will drive the technology. So we are hoping that in the future, some of these things will become accelerated and established sooner. The last thing that I wanted to sort of say, perhaps just to kill time, is to say that we are also realizing that NHS is understaffed. We need better sort of staffing. I was very impressed with the fact that the Chennai experience had 6 wards. They had a large team. They had facilities to look after hundreds of patients. We are struggling with, we have at present 30 odd patients with COVID in our hospital, and everybody is sweating over how much hard work it is. And that's primarily because our teams are 3 and 4 and 5 people. And monitoring these patients and getting the best out of them at present, we are not simply set up for it. We've been cut to the bone. It's something that I don't know whether we will be able to afford and change in the near future.